Please welcome Dr. Michael Donovan, Specialist General Surgeon from Nambour Private Hospital and Sunshine Coast since 2002. He has a broad practice experience with special interest in endocrine and upper GI surgery. Acute surgery is a significant component of his practice. He's a current RACS examiner and was the President of General Surgeons Australia in 2014 to 2017. He's also been the local coordinator, as we said before, to multinational intra-abdominal infection trials. So thank you so much, Michael. We look forward to your presentation.
Can you see that?
Not yet.
What about that?
Not yet.
No. See that?
Perfect. Thank you.
Got it?
Yeah, presenter view. Thank you.
Okay, thanks very much for inviting me to speak tonight. I'm going to talk about intra-abdominal infection from a surgical perspective. This is a huge topic, so it's my presentation tonight is going to be a bit of a potpourri. So I'll start off talking about the surgeon as a gatekeeper for these type of patients. I'm going to discuss the big three pathologies that we would see and intertwine that with how practice has evolved over time. And we've already had, so that's already been touched on in the diverticulitis talk just earlier. And also how there's some science to this, but there's also a bit of art, maybe even dark art. I suppose this is every surgeon's fear in treating intra-abdominal infection, big incision, poor wound healing, pretty ugly looking stoma. And this is, you're really looking at a prolonged length of stay, significant mortality risk, and almost, I mean, there's patients already got surgical morbidity, but this is going to take a long time to heal, and there may be long-term sequelae from it. This is another really difficult, this is a post-gastric sleeve collection. You can see an abscess evolving here. Really, really difficult to treat, and there's no quick solution to this. And this is one of the frustrations for both patients and for surgeons in trying to get this right, because it's a bit of a knife edge type thing. If you don't act appropriately, you get punished, and if you're overly aggressive, you're going to cause excessive morbidity. So there is a real team involved in these, and it starts off with the GP or the referring practitioner. It might be an emergency physician. Often what they say to the patient is the thing that sticks in their mind, in the patient's mind. We've got really good access to radiology these days. Every single patient who walks through the front door is often already had their CT scan, and the radiologist's report carries a lot of weight, rightly or wrongly. We have hospital pressures. Obviously, everyone who deals in public hospital work knows about the day-to-day bed pressures. As surgeons, we also deal with issues getting access or timely access to emergency theatre, getting our elective surgical patients treated in a timely fashion when there's such a high cancer burden and patients with extensive comorbidities. We've got antibiotic pressures, and our AMS team is constantly reminding us of this. We've got this double-edged sword of interventional radiology, which sounds so promising, and perhaps we underuse it, perhaps we overuse it, and I'll talk about that a bit later on. We have competing subspecialties, the cardiologists who sort of, threaten us not to stop their anticoagulation. We have the medical oncologists who don't want a gap in their biological treatments, rheumatologists, etc., etc. So dealing with those specialties which may exist in silos when we've got a real multidimensional patient to juggle. And then in the middle of all this is the patient and their family expectations for what they perceive to be, optimal or acceptable outcomes. So the first of the three major pathologies that we would deal with is cholecystitis. And from an antimicrobial perspective, we really don't cross over all that much, because cholecystitis is usually a straightforward condition. Why are you not operating type of mentality. And that came about as far back as 1970, the first randomized trial looking at same admission cholecystectomy for acute cholecystitis. And over the next 20 years, it got a fairly good traction. And then laparoscopic cholecystectomy came along, and which initially was very difficult. And that was because of the learning curve for surgeons who had not previously undertaken this. The equipment is nowhere near as good as what it is now. And so it went back to delayed surgery, so 2 admissions. And again, over the next 25 or so years, we've had a series of trials showing that same admission cholecystectomy is safe, acceptable, and even beneficial. So our own hospital KPI is to try and get 80% of these patients done as the same admission. The issues, however, are the more protracted the symptoms or the delay in getting them to hospital makes it a more difficult procedure. Sometimes we have patients on anticoagulation which can't be stopped rapidly. It takes a period of time to wash them out. We've got patients who've had previous complex intra-abdominal surgery, making laparoscopic surgery more difficult, and certainly the increasing prevalence of obesity and certainly supermassive obesity makes laparoscopic surgery more challenging for these patients. And then you've got local complications which make the surgery harder. The most common is bile duct stones, but you can also see extension of pathology with perforation into the liver and big polycystic collections, making the surgery more difficult. Sometimes we have incomplete surgery where you do a partial cholecystectomy and leave the back wall of the gallbladder in situ, which drains the sepsis, but does predispose them to a more complex convolution. And obviously there's complications of surgery that we've got to treat the infectious ramifications of. So this is a patient, day 2, has a bile leak. Now, this is not going to get better by itself. This is not going to get better with antibiotics alone. It needs a 2-pronged approach. One, you've got to drain all the infected bile. So that requires a prompt re-laparoscopy and washout. And one also has to control the source of the bile leak, which may be from the liver itself, it may be from the cystic duct, or hopefully not, but a major bile duct injury, which would require extensive reparatory surgery. So often ERCP is very useful for this to identify confidently the source of the leak and also decompress the biliary tree so it dries up. But this patient would generally need a re-laparoscopy with good drainage and then an ERCP, and most would get sorted out that way. This is a patient who had a cholecystectomy, he's in his 70s, had a cholecystectomy for acute cholecystitis, and then presents about 6 months later with just vague, non-specific abdominal pain, lethargy, and CT scan shows a couple of subphrenic abscesses. So there's one here and there's also another one back down there. Fairly easy targets for our interventional radiologists to percutaneously drain, straight there and straight there. And that was done, grew a Klebsiella. seemed to get better, but then recollected, same representation a couple of months later, drained again, and again recollected. And you have to think, what's driving all this process? Like, why are they continuing to occur? And often in this situation, it's spilt gallstones. So this patient ended up going for a relaparoscopy, and some non-opaque gallstones retrieved, all these abscesses debrided, and sort of got better quite slowly. The next topic is appendicitis. And again, we really don't cross over with the infectious diseases community all that often for this. In general, for the last 100 and something years, appendicitis has been considered a surgical condition, i.e. why are you not operating? There's been some recent new changes in thinking. Firstly, laparoscopy is an operation of choice. It allows the surgeon much better visualization. There is a negative appendicectomy rate, so the laparoscope does afford us view of gynecological organs, and also allows you to run the small bowel, get better vision on the small bowel to see if there's another cause for radiolic fossa pain. There's certainly been a dramatic increase in scanning, both ultrasound and also ionizing radiation in the form of CT scanning. It really hasn't translated into a lower negative appendicectomy rate, interestingly. We've also seen, it's become evident there's two types of appendicitis. The ones that are almost self-limiting, and the ones who are generally sick, so the ones who get free perforation, gangrenous changes, and it's usually pretty clear within 24 to 36 hours of the onset of the illness which category the patient's going to sit in. So if someone's been going for a couple of days at home with radiolic fossa pain and tenderness, they're probably not going to suffer from a delay in treatment and perforate subsequently. That process has already declared itself or not declared itself. In the last 10, 15 years, there's increasing use of acute surgical units as models of care, where there's a surgeon and a team dedicated to acute and emergency patients only. So there's not this conflict of trying to treat elective surgical patients and acute surgical patients as a bolt-on type thing. That has led to an increased amount of daylight hours surgery, where you've got, or ideally, a dedicated emergency theatre for use for these type of patients. And again, we're not seeing an increase in complications by not operating in the middle of the night for straightforward appendicitis. And even more controversially, perhaps, is non-operative treatment of appendicitis. It has been performed in some parts of the world in paediatric population for decades. Before the advent of anesthesia in the 1800s, it was probably done, although people didn't appreciate it at the time. But in more recent times, it has been shown to be safe and effective. I think most surgeons are aware of it, but are reluctant to embrace it as a standard of care. So complicated appendicitis, fortunately, is not all that prevalent, but we do, if we treat in our hospital 50 cases of appendicitis a month, a couple of them will be associated with abscesses or generalized peritonitis. I'll present a case of a 62-year-old man who was transferred, obese, newly diagnosed diabetes and hypertensive. He'd been grumbling on for about a week with symptoms. He wasn't unwell, but he did have certainly localized tenderness, and the CT scan showed complicated appendicitis with an abscess. He underwent a laparoscopic appendicectomy the next day. It was a gangrenous appendix, and the abscess was drained appropriately. A surgical drain was placed and it was removed on day 1, and his intravenous antibiotics stopped at that time because he looked better and he was discharged. Unfortunately, that wasn't the end of it. He was represented a couple of weeks later with the same sort of symptoms, pain and fevers, and a decent sized collection at the site of his previous abscess. That was readily drained by an interventional radiologist, a couple of days of intravenous antibiotics, and then 10 days on oral augmentin at home with satisfactory resolution. So why did this occur? Is it the pathology? That certainly does predispose to post-operative abscesses, and certainly incomplete drainage at the time of surgery sets people up for post-operative abscesses. What we are seeing with the uptake of laparoscopic appendicectomy is there's less of an abdominal wound because of the keyhole nature. So you get less cutaneous wound problems, but you get more deep space abdominal infection problems in these bad appendicectomy patients. Diverticulitis is the next group. We've spoken about uncomplicated diverticulitis already, and I was going to concentrate more on the complicated ones. Just to reiterate what's already been said, there's no evidence that inpatient care is better. And there's even going the next step, do antibiotics help at all? Is this a self-limiting condition that gets better in spite of what we do? Again, as Raquel alluded, it is slow to adapt in the surgical community. This has been discussed, for 10, 15 plus years. And I think, again, all surgeons know about it, but are a little bit reluctant to embrace it wholeheartedly. The complicated diverticulitis patients, they fall into 2 groups. Either they've got generalized peritonitis, where they're very unwell and they need emergency surgery, or these patients who present with localized abscesses where there's been a perforation but it's been walled off by surrounding viscera. I'm going to present a couple of cases of those. So this is a 30-year-old lady who presents just prior to the COVID outbreak with what was initially thought to be uncomplicated diverticulitis. So she got 4 days of intravenous antibiotics. With the benefit of hindsight, maybe there's a little, diverticular collection. It certainly wasn't recognised at the time. That's not a sackable offence at that stage. She did represent a couple of weeks later with the same symptoms. This time the radiologist mentioned a left pelvic adnexal collection. Was it tubo-ovarian, a simple cyst, or was it related to the diverticulitis? And that led to a whole chain of gynecological investigations which didn't reveal anything. So further intravenous antibiotics, again, got better. Another admission in March, same symptoms. June, another admission. This time, a fairly obvious collection, 53 millimeters in the mesorectum. Had more antibiotics, sort of got better. Just as an aside at this point, in general with intra-abdominal infections or intra-abdominal abscesses, under 3 centimeters in size, from a surgical point of view, will probably get better without an intervention. Greater than 50 millimeters in size probably won't get better without an intervention. And the group from 3 to 5 centimeters, you kind of hedge your bets. At this stage, she was just, for whatever reason, she was treated with more intravenous antibiotics, and again, sort of met discharge criteria and went home again. By August, we've got a pretty impressive walled off collection, rim enhancing, and she's not better. And it's fairly clear to all and sundry that an intervention is required. So she got a radiological procedure, and our interventional radiologists, they're pretty good at finding ways to drain abscesses. So this one was drained transgluteal, good collapse of the cavity. Pigtail drain going through your buttocks, not the nicest thing, particularly when you have to sit and lie on it. And every time you extend your leg, it's going to wiggle a little bit. Anyway, she had 2 weeks of intravenous antibiotics, and the drain managed with community nurses through a HITH-style program, and booked for a semi-elective operation. So she underwent a laparoscopic anterior resection, did very well, a 3-day length of stay post-operatively, which is kind of what our colorectal surgeons would expect for elective colectomies. But in view of all this sepsis, something bad was due to happen, and she got a deep wound space infection, which did require another readmission and another procedure to wash out. Eventually got better. In summary, this lady over the course of under a year scored 9 CT scans and was seen by 5 different surgeons through an acute surgical unit. And perhaps this is one of the disadvantages of an ASU style model with a rotating surgical workforce going through it, is that ownership of the patient once they leave the front door can evaporate, and once it's sort of the not my problem once you're off the ASU team. And that's something that we will improve with time as the models of care sort of get bedded down. Next lady, 72-year-old lady, again, pretty standard acute diverticulitis. She had a decent peridiverticular collection over here. A couple of days of antibiotics while we organised a radiological drain, which was fairly straightforward for them. They went straight through the abdominal wall. Improved quite quickly, had what seemed to be an appropriate course of oral antibiotics. Now at this stage, I'm just going to divert into the evidence about the treatment of the longer-term treatment of complicated diverticulitis. Traditionally, if you had a series of admissions with diverticulitis or a complication such as this, you would be offered an elective sigmoid colectomy or anterior resection to remove the source of the problem. More recently, those guidelines have been relaxed, and there doesn't seem to be any improvement in outcome in terms of representations with further diverticulitis, morbidity, complications, that sort of stuff, by not offering them elective operation. And that's the way we've kind of gravitated, that you really have to earn your sigmoid colectomy. So this one was drained. She completed her course of treatment, but unfortunately represented a month later. So the first scan's on the left of your screen, and the subsequent CT scan after a month is here. And this time I think we did better and treated her appropriately with antibiotics, and had early discussions about, where are we going with this particular illness, and offered her surgery at that same admission. So it was a planned acute surgical unit list, probably going to be a stoma, but it just depends on what was found intraoperatively. Fortunately, she was able to have anastomosis out of the contaminated field. Not a straightforward recovery, had an ileus, did require TPN and about 2 weeks hospitalisation, but since then it's been satisfactory and just seen as an outpatient. So just wrapping things up, interventional radiology, I think as it becomes increasingly available, is a double-edged sword, as I said earlier. It certainly can diffuse a situation, and I think I've shown that in some of those cases through the presentation. However, it doesn't necessarily avoid the need for an operation. We do have delays in obtaining IR. It's not we don't have a 24/7 on-call roster for them. It's only Monday to Friday, 8 to 5. And in terms of someone undergoing an interventional radiology procedure, it can delay a decision for definitive management, again, as I've shown in those cases. And it is akin perhaps to kicking the can a little bit further along the road. In summary, the surgeon remains central in decision-making for patients with intra-abdominal infections. I think over my career, the team involved has become multimodal, and increasingly we're thinking about what that particular patient needs. We haven't got it right, as I've alluded to, but one thing I do see in the team and my colleagues is we are talking about, with the frail patients and the oncology patients, about limits of care before we get too far down the road. I'd just like to say to my juniors that we sometimes get a little bit trapped in short-term day-to-day goals, and we need to make a conscious effort to think about the big picture for the treatment of this patient. Thanks very much.
Fantastic. Thank you so much, Michael. And what a smorgasbord of interesting surgical cases that you've shared, and certainly a lot of food for thought.